Hello, good evening, everybody, and sorry for the delay from my end. Yes, today I'll be talking about scapular dyskinesis. It's a very interesting topic for all of you today because this is an upcoming thing. Nobody was talking about scapular dyskinesis 20 years ago. There was this gentleman, this surgeon, Ben Kibler, who introduced this terminology, I would say. It was called scapular dyskinesia initially, because as a clinician, he's found that a lot of people had abnormal movement of the scapula for those who had shoulder pain. And he wrote an article called as the sick scapula in sports. And from there, I think this has picked up tremendously. The research that has gone in assessing scapular movement has been tremendous in the last 15, 20 years. Um, I think scapula being moving abnormally was always known because there have a lot of studies before that as well. But a lot of them were just focused on the amount of scapular upward rotation because that was the only movement we could measure with an X ray. But later on, with technology, as we could assess the scapular movements better, we identified what was dyskinesis actually. And there has been a lot of research recently as to its significance. We'll talk about it. We'll look at a lot of videos. And I hope those videos are useful for you for making an assessment of what dyskinesis actually looks like. Okay, so the possible cause for a rotator cuff pathology now we believe is an abnormal movement, and that is the most interesting thing for me as a physiotherapist because that is where I can intervene. If it is an abnormal movement due to a muscle problem, or either a muscle is tight or a muscle is weak or there is other motor control issue, then that is a place where as a physiotherapist I can intervene and make a correction. So to give you certain numbers, all rotator cuff pathologies initially, not all I would say, but the many of them were undergoing a surgery, acromioplasty, and that was one of the commonest surgeries being performed in shoulder. With the new information now that we have, that the problem possibly is not the acromion. Remember, Neer and Biglani had said that there were these three types of acromion, and the type 3 acromion is the reason why subacromial tissues get compressed and inflamed. And that is the reason surgeons thought that they could just remove the acromion and that would solve the problem. But it did not solve the problem because possibly it wasn't the source of the problem. The problem was something much different. It was the abnormality in the scapular movement, which possibly causes more compromise of that subacromial space, causing inflammation over there. So the focus has now changed from the abnormal acromion to an abnormal scapular movement. And sorry, so the role of physiotherapy has also gone up for all shoulder pain. Sorry. So let's briefly talk about what happens in normal movement. So if you all were to keep your hands in front of you, as if your hands were in front of, as if your hands were on top of the scapula of somebody, and I'm just going to mimic the movements that are going to happen as you elevate your arm. So as you elevate your arm, your scapula do a movement, what is called as upward rotation, which in this figure over here is in the center where the glenoid is now facing more and more up. So as you say in this figure, you can see that as the glenoid faces up, that is upward rotation. That is the predominant movement of the scapula. It has been known that there is a scapulohumeral rhythm, and the scapula upwardly rotates almost in the ratio of 2 is to 1. That is, that for every 2 degrees movement at the glenohumeral joint, there is 1 degree movement at the scapula. So if you have total of, let's say, 180 degrees, roughly 60 degrees movements comes from scapular upward rotation was what was um, postulated in the earlier studies, and that ratio of 2 is to 1 holds more or less true even till date. So this is the predominant movement, but scapula also does two more rotations. And the next rotation that I'm going to talk about is called as anterior or posterior tilting. That is the graph C over here. So when the inferior border of scapula moves towards the thorax, that is posterior tilting, and that is the normal movement of scapula. So as you elevate the arms, the inferior border kind of follows the contour of the thorax, and the inferior border moves towards the thorax as you elevate the arm. An abnormality would be when it protrudes outwards. So posterior tilting is the normal movement. And the last normal movement that the scapula performs on the last axis remaining, again following the contour of the thorax, is internal rotation over here. So the predominant movement is upward rotation, it does posterior tilting, and it does internal rotation for almost throughout the range. Only in the terminal elevation does it externally rotate. Internal rotation is when the medial borders come away from the thorax, right? External rotation is when the medial borders move towards the thorax. I'll just show you a couple of videos to clarify what normal movement looks like. So this is a 3D skeleton reconstruction that we did in our lab. It shows, come back to this video again. It's a nice video of how the normal movement happens. But for everyone's reference, it upwardly rotates, posteriorly tilts, and internally rotates. Okay, so what is dyskinesis? So any abnormality from this normal movement is called as dyskinesis. It was initially called dyskinesia, but now we like the term dyskinesis. But whatever we call an extreme protrusion of the medial border or the inferior angle of scapula, when the medial borders and inferior angle become very prominent when you raise your arm or lower your arm, or this asymmetrical movement that we see is called as dyskinesis. Now, there are very various types of dyskinesis that you may find in literature. There is dyskinesis, which this is called as winging. Winging is a term restricted to use when you have a long thoracic nerve palsy and which causes serratus palsy, and then the medial borders really protrude out. But this prominence may be termed as winging in certain books that you may see. There is excessive anterior tilting, that is, the inferior angles really pop out backwards. A sudden lowering of scapula while lowering of the arm. So, as I said earlier, the scapula upwardly rotates while you take your arm up, it downwardly rotates when you get it down. When it happens suddenly, like the scapula is also, it's almost called a scapular dumping, that there is a sudden scapular downward rotation while lowering of the arm. That is also called dyskinesis. A slight elevation of the whole shoulder girdle, which you see normally patients doing, is also sometimes called as dyskinesis. So any abnormality of scapular movement is called as dyskinesis, and I'll show you a few videos, and I hope they run. To make it more apparent as to what it means. So observe the medial borders and the inferior angles as the person elevates and then lowers. So if I were to ask you as a clinician, it will be very easy for you to say that the right scapular border is extremely prominent, especially during lowering of the arm. Pen and the plate. But right about here, you can see this inferior angle, and there is an asymmetry. The inferior angle becomes too much prominent on one side. This is another video. Video is not running. So this one is running now. So you will observe that in most cases, the medial borders and inferior angles are not so prominent while elevating the arm, but they become prominent only while lowering. I put this video up because you see a prominence, but it's pretty much symmetrical, and I would not call it dyskinesis. And you would find such certain scenarios many a times in your clinic that you would be confused. Assessing dyskinesis is also challenging, especially in female patients in India, because you cannot get adequate amount of declothing done. It's difficult to visually assess for these shoulder blades, and then you have to palpate or imagine. So again, assessing dyskinesis then becomes challenging. These videos run here. Good. So you see on the right and the left, I'll just play this again. There is an apparent asymmetry that you can see. The first trial, it is not so apparent, but in the second trial, you suddenly see that the